Excellent. So we are now recording. Welcome everybody to the National Care Coordination Academy. This session is going to be excellent. We have a really great day planned for you. I will first let our principal investigator, Meg Comu, say a couple of words of welcome.
Hi, everyone. Thank you very much for joining us today. As a Medicaid policy wonk, someone who's passionate about the impact that Medicaid has on children with special healthcare needs and children with medical complexity and their families, I'm really excited to learn from and with you all today. This panel is going to be outstanding, and it is a great opportunity for us to be able to get input and insight from those who are on the front lines doing policy. And so I thank them very much for sharing their time with us today. I thank you all very much for sharing your time with us today, and we hope that you find this as great a learning opportunity as we've hopefully designed for you.
Thank you so much, Meg. And I just wanted to introduce myself briefly because I know we do have a couple of new faces. My name is Heather Pamela, and I am the manager of the National Care Coordination Academy. We are really grateful to have all of our new faces joining today. So I'm going to do a couple introduction slides. I won't take up too much time since we do have a busy agenda for you. But as noted, this meeting is going to be recorded. The breakout groups will not be recorded. Everyone is going to be on mute for this session, just given that we have a panel discussion going on today. If you would like to speak, we ask that you put your questions and comments into the chat, and we can invite you to unmute if there is timing today. Very important, we would love to have you please rename yourself to include your state team name first, so that your state initials, and then you can do this example over here with an underscore and then your name. To be able to do that, you go to the participant area, find your name, right click on your name, and then you're able to type in putting your state abbreviation first and then your name. This is very helpful when we do get to the breakout session, so we're able to place you appropriately. Thank you. Okay, so as always, my son Thomas has been on this journey with us, so I always find a way to share him. He's now almost 6.5 months, hard to believe, but he is excited to always let you guys know about your continuing education credit offering. We're approved to offer credits to RNs, NPs, MDs, PAs, and social work. The process will be similar. We will share the attendance Google Doc in the chat. We will ask at the end that you complete the evaluation. On the attendance Google Doc, you will share your best email address, which will be sent to the Boston Children's CME department. You will then, within 2 to 3 weeks, receive an email from the CME department outlining the way that you're able to request your credit certificate. And another exciting announcement, we have a new opportunity for you to get more credit. Participants are now able to get credit for watching our recorded lectures on open pediatrics for up to 6 weeks after the live event. So today's event will be uploaded by tomorrow. You'll then be able, if there's anyone from your team that missed it that wants to see the recording, they can view the recording. They can let me know that they watched it, and I will share the evaluation with them. And this will be going forward for all of our events. And Thomas has a special message of be happy and be kind. Okay, and these are some slides that we wanted to share from our friends at HRSA. This is a public service announcement. I had sent an email to you all letting you know about the special enrollment period that's going on for enrolling in health insurance coverage given the COVID-19 public health emergency. This is available right now. It started on February 15th and is going until May 15th. So very important to let your friends, families, and patients know about this opportunity. Just showing you, so the number of uninsured children has unfortunately increased since 2016. So that's why it's just really amazing that there's this opportunity right now to encourage improved healthcare coverage for our children. And this sort of goes without saying, but of course, if health insurance, if our parents are covered, it's going to improve that our children are covered and overall improve health. So please go ahead and share this opportunity. If you missed the email that I sent, I'm happy to share it to you again if you need any further instruction on how to share this great news. All right, Rich, I'm going to hand things over to you. Thank you, everybody. I hope you have a great day.
Thank you, Heather, and welcome everyone from the beginning. And I want to continue this tradition of expressing our deepest gratitude for the ongoing commitment and partnership and collaboration with our HRSA Maternal Child Health Bureau colleagues. You'll actually be hearing from Dr. Michael Warren later on in this session, and Anna Maria Padlin, who is the project officer for the Children with Medical Complexity CoIIN at BU, Dr. Mann, Ms. Brown, Ms. Scott, and Ms. McClellan. So thank you very much for your ongoing support. Next slide, please. So I want to really make an announcement, an observation, if you will. The journey started pretty much in the middle of the first phase of the pandemic, and HRSA and MCHB said, we need to get something off the ground. Families need this. And at the beginning of the Care Coordination Academy, there were topical sessions because we wanted to do level setting in terms of content for everyone. And then the periodic sustainability affinity groups going forward. After today's session, we're actually going to be blending those. And we're really thinking about what are the waypoints that we're going to be looking for and guiding each of our Academy participants. There's going to be a commitment to sustainability and reflected sustainability among three broad domains. Elements of the care model. A lot of that work has been done by the Maternal Child Health Bureau, the medical home and care and integrated services, et cetera. Financial sustainability, and then performance measurement. So these three domains will be the lion's share of the content going forward, with the North Star being sustainability of care coordination for children with medical complexity and children and youth with special health care needs. And let's go to the next slide, please. And so I want to just give you an overview of the agenda for today. Dr. Warren will be making some opening remarks. Then we are going to, Jeff Schiff is going to be introducing this panel of Medicaid Medical Directors, and moderator is Ellen Marie Whalen from CMS. And really what I want people to think about is today's session is purposely designed to identify areas of potential synergy and alignment between priorities of Medicaid at the state level and CMS at the national level, and the Title V community, and what's important to patients and families and the delivery system. So if today has a sense to you, a feeling for you that we're trying to make a connection, a harmonization, if you will, that's exactly what our intent is. And then that will parlay the Care Coordination Academy into that phase of sustainability. Next slide. So I'm going to hand this over to Dr. Schiff, who will be introducing Dr. Warren and taking us forward.
Great. Welcome, everybody. And my introduction is going to be short because we want to make sure we get stuff. But it's a pleasure to write to Dr. Warren and ask him to say a few opening remarks and to come. I think he can be here for a bit this morning or this afternoon. Dr. Warren hails from Tennessee, where he, I think, very soon after his residency became worked in the Office of Children's Care Coordination, and then a deputy commissioner and associate commissioner, and then became the associate administrator, which seems like the wrong title for somebody with as big a job at the federal level as this. But Michael, welcome to the session, and we'd love to give you a few minutes to say hi.
Thank you so much, Dr. Schiff and Dr. Antonelli, for the introduction and for inviting us here. It is good to be with you all. I hope that wherever you are joining from, it is as sunny and spring-like as it is in our nation's capital. It is a welcome relief after the many challenges of the recent past. And so I hope this finds you all doing well. Thank you, first of all, for all that you have been doing during this time. We're approaching the 1-year mark for many of us where we started this very different way of living and caring for patients and approaching systems. And so thank you for your perseverance during what has been an incredibly challenging year, not only for the populations we serve, but for many of the folks who are actually doing the serving. So I want to thank you for that first and foremost. I love that you all are engaging Medicaid today. As Dr. Schiff mentioned, I spent about a decade in Tennessee. And one of the things I realized early on was that if we were really going to have an impact, we had to engage Medicaid. When we think about the scope of covered lives for MCH populations, Medicaid plays a huge role. And yet, if you think about the expenditures and the operations, that may not be what's on the forefront of your Medicaid agency's mind. And so what I realized very early on was the people in my state Medicaid agency were perfectly nice and wonderful people, but the things I was caring about maybe weren't always on the top of their list. Not because they didn't care, but there were lots of things that were going on. The scope, both in terms of dollars and rules and regulations that I was working with under Title V, were more narrow than what they were working under, thinking about all of Medicaid. And so there was the opportunity to do some relationship building. And I think you're going to hear some of that come out today in ways that people have worked in state Medicaid programs to connect with Title V and state public health programs. And so I'm excited to be on for part of this and hear some of those stories, and for you to hear them as well and think about where there are opportunities. Some of you have heard us talk about this bureau framework that we're using called Accelerate Upstream Together. And as I was thinking about what I wanted to share with you today, one of the examples that popped up immediately for me was around medical home. So we were curious a while back, how long have we been talking about medical home? And we went on a quest for what is the first published mention of medical home, because we talk about it now like we all know what it means and it's the expectation that it exists. So the earliest print record we can find of this was 1967, and this was doing some digging with our colleagues at the AAP Historical Collection. And so Dr. Cal Sia, who many of you knew and many of us hold up as a hero, was one of the first champions of this. And at the time, really, there was this concept of a medical home, a place where all the records were kept. These were back when kids had these multiple charts and stacks of charts. And so there was this sense of having a place where records were kept and care was coordinated and people were talking to each other, and families were at the center of that. That concept has certainly grown over time in terms of we aren't talking about a physical space anymore, but really about this approach to care. But we've been talking about it since 1967, 54 years now. So you would thought we would have gotten this right? And that everybody would have a medical home now or receive the medical home approach to care. But it's curious, if you look at our national survey data, so our National Survey of Children's Health is done annually. We survey a representative sample across the country, but also have representative data at the state level. And if you look nationally and say, where are we in 2019? So that's the latest data. So 52 years after we first started talking about medical home, less than half of all children in this country, their parents report receiving care in a medical home. And so you might say, well, you know, that's for all kids. Surely for kids with special health care needs, that number would be higher because they really are often the population that we think about really encouraging this for. You would think that, but it's actually lower, right? So it's about 48% nationally for all children, about 43% for kids with special health care needs. And I think germane to our conversation today, if you look at kids who are publicly insured, it's even lower. It's about 38% of families that report their kids receive care in a medical home. Now, I hear numbers like that and I scratch my head because I think about the expansiveness of EPSDT as a benefits package and the spirit of that. And you think every kid who's on Medicaid ought to have a medical home. But 38% is where we are. So when I think about this Accelerate Upstream Together framework, I can't think of a better case to make for Accelerate than the fact that only 38% of kids on Medicaid have a medical home. We have to do better. And 54 years from now, colleagues who come after us and are talking about medical home, which will then be 100 or so years old, can't be having that same conversation. The upstream piece of that framework is also important. And I think our colleagues in Medicaid have actually been really pioneers in thinking about how we address some of those upstream determinants of health, social determinants. So things that even 10 years ago, we would never have thought about being able to cover. Medicaid programs are finding a way to do that. They're thinking about those social determinants that are strong influencers of the way people experience health. I think that there's great opportunity to continue to move upstream and to think about structural determinants of health. So as we think about, for example, the impact of systemic racism and the impact of bias, how do we fold that into the work that we are doing and that payers are doing? So we talk a lot about value-based care. Value to whom? How do we figure in patient experience into that equation? And how do we look at equity with that? Because it's not helpful to look at value as a percentage at a really high level across the population if different members of that population experience value differently. And so if we really want to move toward equity, there's that line in quality improvement that says what gets measured gets improved. I think if you extend that into the clinical care space, what gets paid for gets improved. And so if we start to think about value and tying value to equity and looking at value across populations, it's not enough just to raise the perception of value for your overall population. You need to look at that across populations and think about how we tie that to reimbursement and to really move that along. So it's thinking upstream in ways that we haven't done before. So accelerate upstream together. The together part is really simple. Title V can't do this alone. Like I said, you've got, I wish you had a much larger budget. I wish we had more to be able to give to you, but we have what we have. We do a lot through partnerships and relationships. And your MCH expertise, your Title V expertise is so valuable to state Medicaid agencies. A lot of the things they are interested in, you are interested in as Title V. And so, and you're gonna hear from Medicaid today and partners. And so it'll be helpful for them to tell you the kinds of things they're interested in and ways that Title V has brought value to the table. So that together part of Accelerate Upstream together is really key. And I would say, as you're thinking about the together, don't forget, and MCH folks do a really good job of always remembering this, but don't forget about the reason we're here, and that's the families that we serve. Bring them into those conversations early. And this is not just for a token seat at the table to say, check the box, we had a family member there. Think about how you give them power and opportunity. How are they involved on the very front end pre-decisionally about telling you what they need? Because we're often really good at thinking about what we think families need, but they can tell us what they really need and how the systems ought to be designed. That matters because at some point, families, consumers report on their satisfaction. They report on the adequacy of their coverage. And those kinds of things bubble up and payers care about that. So all the more reason to get families involved on the front end and make sure that the systems we're designing, the approaches we're designing are working for them. So Accelerate Upstream together. It's the framework we're using. It ties nicely, I think, with this work. Couldn't be more pleased at the work that this academy is doing to support you all in states, and particularly we're excited to be able to hear this conversation around Medicaid today. So thanks for inviting us to be a part, and we look forward to listening.
Thanks, Michael. We can go to the next slide. I'm going to do a little bit of an intro for a few minutes here and then turn it over to Ellen Marie. So just because we're doing CME, we always talk about this. These are our learning objectives, understanding ways to engage with Medicaid programs, understanding the role of the Medicaid Medical Director and the best ways to collaborate with state MMDs to approve or improve and sustain care coordination programs, and then understand the ways Medicaid programs track service use and quality. So we have a lot to cover. We're going to have a robust discussion. I want to remind a couple folks of a couple things. We're recording, so so everybody knows that. And I also really want to encourage the chat because it's a lively way. I've been reading a lot, as I'm sure a lot of you have, about how we're all sort of stuck on Zoom without the social interactions that we used to have between and at the coffee pot or at the water cooler. So I encourage you to do the best you can to make that happen. Next slide. We're doing this session for a while this morning for me out in the Mountain Time Zone, and in the afternoon for the rest of you. And then we're going to go off into breakout groups, not breakup groups. And we want to have you maybe focus in your discussions around these questions: your current relationship with Medicaid. Have you prioritized activities and implementation sustainability with Medicaid and the Medicaid Medical Director? And if so, what are they? What are the outcome measures? And it said, the last question I actually rewrote, I hope you learned something. So I would say, what did you learn? Not did you learn something? What did you learn today? That would help. So we're looking forward to that. All righty. Next slide. This is the thing I'm most excited about doing in the intro. For those of you who have not been at the SAGs, the Sustainability Affinity Groups, we have been doing a little travel log. And so this month, as we were preparing for this, I thought, what could be better than going to Mars? And the travel log, I was inspired by the fact that the developers of Perseverance wrote in code into this parachute, "Dare mighty things." The entire quote is from Theodore Roosevelt, and it says, "Far better is it to dare mighty things, to win glorious triumphs, even though checkered by failure, than to take rank with those poor spirits who neither enjoy much nor suffer much, because they live in the gray twilight that knows neither victory nor defeat." So my recommendation for us is that this Care Coordination Academy adopt the rover named Perseverance as our mascot. Perseverance is steady persistence in a course of action, a purpose, a state, etc., especially in spite of difficulties, obstacles, and discouragement. If anything defines perseverance, I think it's both the Academy and the work that a lot of the people here have done to make the lives of children with special healthcare needs and their families better. We are the folks, and I think you are the folks who are doing the doing that is really challenging. So as Rich said, we've been working on sustainability in the SAG, and we're bringing some of that here today. As both Rich and Michael have said, Medicaid and private insurance are some of the juggernauts we have to deal with. So I want to just introduce the Medicaid Medical Directors as a concept. The Medicaid Medical Directors sit at a juncture between policy and practice in their state Medicaid programs. They are the folks who know the clinical side of things and know the policy implementation, which is why we have them here today. Medicaid Medical Directors mostly work on benefit policy, quality measurement, and system improvement. And the folks who are here today do all of that. As a network, the Medicaid Medical Directors have been getting together for just under 16 years. I'm happy to report that about half of the Medicaid Medical Directors are either pediatricians or family med docs, and that we as a group share and steal from each other. We try to populate national committees and do projects of national significance. And now the group is restarting a strategic plan that hasn't been done for about 8 years. And I'm sure one of the things that has already come up really loudly is around multi-state quality improvement. So we've asked some of our colleagues to come and talk to us in person today about this. And if you go to the next slide, I just want to introduce the folks who are here. First of all, we're really delighted that Ellen Marie Whalen, who is the Chief Population Health Officer at Medicaid and a pediatric nurse practitioner, it will help and moderate the session. And Ellen Marie certainly knows this, this part of this work from the national and federal side. Some intros of the panelists. If you go to the next slide, all my pals. Tom, I'm going to do a very quick introduction so we can go off to the discussion, but Tom Lind is a pediatrician who is the Medicaid Medical Director in New Jersey, and I'm happy to say went to the same residency as I did at Geisinger, and is part of an Inc. state. Ryan Van Ramshort is the Chief Medical Officer in Texas. He is relatively new, and I just want to read a quick quote that was in his bio that I think is great. I have been working with Medicaid CHIP policy since I was a medical student, and have sought to educate myself and others about its importance. So Ryan gets it, and we're really happy to welcome him. Curtis Toma is the Medicaid Medical Director in Hawaii, and is a med peds person. And I want to say that at the last strategic plan, Curtis pulled me aside and said, Jeff, I really want to do something about children and youth with special healthcare needs. So he's been thinking about this for a long time. And last but not least is David Kelly, who is not a pediatrician, but he has done so much work on pediatrics in the Medicaid space that we've considered him an honorary pediatrician, including serving on the child core set. And David is really understands about his agency and how to move the Medicaid system. So with those intros, Ellen Marie, I'm going to turn this over to you to start our panel off. Thanks, everybody.
Thank you, Jeff, and thank you for inviting us to participate. One of the things that I've been really fortunate to work on over the past couple of years is some partnerships with Dr. Warren and the folks over at the Maternal Child Health Bureau on the relationship between Medicaid and Title V. And I've actually learned a lot over the past couple of years about how that works. And we've been working together to be able to identify where there are some good examples of this partnership and things that would not have happened had it not been for that partnership. And I'm looking forward to hearing from the Medicaid medical directors today that have talked, thinking a little bit more about that. Also, hopefully we've got 2 hours for this panel, and hopefully we'll be hearing from folks across in the audience that are here that will tell us about some of the things that they've been doing where they've been able to partner with Medicaid and Title V. So I think that's where we're going to start with a little bit of that. And then as you can see from the screen here, we'll be then talking about, as you're moving forward with the care coordination activities that you're doing, ways to be thinking about getting that integrated into some of the programs or obtaining approval. And throughout, I'll be talking a little bit about some of the ways that we're thinking about this stuff over at Medicaid. After we get the go-ahead, and that's a little bit about the way we think of it, then how do you implement the ideas that you have into the program itself? And then, of course, at the very end, the most important thing in some ways just to track success is being able to measure it and having the right measures. So I'll start a little bit about Medicaid and Title V. With obtaining approval, as we go through, I'll talk a little bit about letters that we have put out, and I think Dr. Warren just referenced them. We have a letter that went out to state Medicaid directors on how to do a better job with value-based care. And then we did a sister letter on what states could be doing in terms of social determinants of health. And we're really excited that those things happened back in September, and then in just as recently as January, letting states know what options they have and what they could be doing in addition to what Medicaid must be doing. And I think that's a really important thing that I'd like to be exploring today as we talk about some of these activities, is talking about the difference of what Medicaid has to cover and the whole host of things that they can cover. And Medicaid tends to do a much better job talking to Medicaid directors and the states. And I've been on a mission to try to have these explain how Medicaid works to the lay public, to clinicians, to families, to advocacy groups, so that you all know, even though your state's not doing something now, they have the option to do that. And sometimes you need to talk to the state legislatures on how you could move that forward, because while Medicaid is a state federal match and most of the dollars come from the federal, the states still have to come up with their dollars. And then we'll talk a little bit when we get to the implementation, a little bit about how each state would move forward. And that's different for each state. The issue itself might be the same, but do we choose a state plan amendment? Do you choose the managed care plans? Do you choose 1115 demonstrations? And we'll hear a little bit from all of you about how far we want to dig into this. This is something that I, of course, could talk about for a long time, and I think is important to kind of understand where your states are and how these things move forward. In addition, this doesn't have to be the last time we talk about that. Dr. Schiff and I have been talking about the other work that you're doing in sustainability, and there might be other opportunities to talk about this. We acknowledge the partnership of what Title V will fund, but as Dr. Warren just talked about, it's really important to figure out so it can be longstanding and so it can continue without needing to find dollars here and there, how you can integrate that into the Medicaid program. And then lastly, we'll spend a bit of time talking about measuring success and the different ways that are out there right now that are measuring opportunities, including the Medicaid core set, as Jeff just mentioned. There are things that we look at through EPSDT and other ways that we're measuring success, and I think this is a real opportunity for this group, is ways that all of you can talk about what is successful. I spent a number of years working with awardees through the Innovation Center at CMS who were doing delivery system reform. And one of the things that we talked a lot about was each one of you shouldn't have to figure out what the message is. Collectively, this is a great opportunity for you to be able to talk about where is the evidence of why this is so important? Have the message be the same when you're talking to your state Medicaid directors, when you're talking to managed care organizations. You shouldn't have to come up with the story of why this is successful individually. How you implement it might be different, but that story of the proof of the evidence of why you're moving forward, why this is critical and why it can be cost effective is something that is a really important message. Lots of times folks talk about it as the elevator speech or the one thing that you're going to put in a takeaway in one page as you move forward. And being able to work across all of the states that are participating here today is a real bonus that you don't have to think this through on your own. So let me just spend a couple minutes into, Jeff, did you start to say something?
Nope.
Okay.
No.
Just a couple minutes about the relationship between Medicaid and Title V, and then we'll turn it over to the Medicaid Medical Directors to talk about what's happening in their states. And as I said, I've learned a lot about this organization thanks to Dr. Warren and his team over there. And I was noting that the first mention of the Medicaid or the health home, medical home, was in 1967. And in fact, that was when EPSDT was first designed, which was 2 years after Medicaid. And that was the first mention of the importance of integrating Title V and Medicaid, and it was through that EPSDT work. And there is in fact legislation in both Title V as well as Medicaid that there's a requirement for these groups to work together. How that happens is very different in every state. We've spent some time working with the Maternal Child Health Bureau and trying to understand where there are successes and where there are ways that we could work better together to help the states do a better job working together. And so I appreciate us continuing to work at that at the federal level and also hearing more about what the states are doing and where there are opportunities there, and potentially then to look to see if there are things that we could do at the policy level to try to strengthen that relationship. I'll also, I want to thank Heather for flagging the open enrollment period, just as a kind of a public service there too. We're excited that that open enrollment period is up again now. And I'll also note, goes without saying, that we have a new administration who are looking for new ideas to improve accessibility to care, to improve coverage, to improve outcomes, and especially looking at equity. That's something that we've heard so much about over the past month. And we know that it's not all up to us and it's not ideas just generated from us. So we're really looking forward to hearing how we could be doing a better job from all sorts of folks. And I'm looking forward to hearing in the next couple hours ideas that you might have of how we could do a better job. So let me stop there because I want to mostly move to our panel and get the conversation going. So Jeff, I'll turn it over to you. Once you get off mute.
Now I got off mute. Sorry. You know, I wanted to just two things. One is I want to acknowledge a couple of our panelists may have to leave early, but hopefully we'll be able to stick around a little bit longer. But we really broke this up, and we really wanted to ask first the panelists, and I won't. If you're quiet, I'll call on you. But otherwise, I'd really like to hear from all of them a little bit about their working relationship between Medicaid and Title V, what's worked in their state, what hasn't worked, and maybe what they would like to have work better in the future. And I don't know if anybody wants to jump in first. Otherwise, we'll go from east to west and then back from west to east. So Tom, I see you on the screen. Can I call on you?
Yeah, I was going to say either way, I'm on the hook if you're going east to west there. Good afternoon, everyone, or morning, depending on which time zone you're in. I am the medical director for New Jersey Medicaid. This is unfortunately, the Title V in New Jersey is administered through our Department of Health, and Medicaid is in our Department of Human Services. And we have made good progress as far as working collaboratively. That's one of the things that we've really has been a benefit of the Title V program. The initial use of the funds was through several different pilots through the Department of Health regarding SIDS prevention, women and children special health care needs, CHWs, community health workers, adolescent health initiatives, case management for youth with special needs. And the most impactful at this point, I think, would be our doula program. There was a Department of Health initiative with women of color, serving women of color through a doula program training initiative. And the Usazi Village was chosen as the curriculum of choice. 79 doulas starting in 2018 were trained and have been put into practice in specific communities. Medicaid and the Department of Health developed an MOU and have been working collaboratively to develop a broader doula initiative. And I'm happy to say that we went live January 1st with allowing straight doula reimbursement through Medicaid. And we've been working out the kinks as far as the certification, the credentialing, the billing processes, and we're making good progress on that. We've really, this is the best I've seen DOH and DHS work together, and I think we've really made strides in that. And so we have developed a stakeholder group of doulas throughout the state and have developed good relationships as far as working with doula groups to try to assist them as they move forward. And right now, I think we have 79 doulas that are DOH trained, and then we have other doulas that are entering the program from other avenues. This is also includes a doula registry, which is going to be New Jersey specific, and a doula learning collaborative, which is going to be supportive of the doula community and associated specialties. So the broader initiative is the Healthy Women, Healthy Families initiative. And these are just a sampling of the types of programs that have come under them. I think probably the initiatives have led to legislation because we've had several things that have been legislated. One of them is doulas. Other things, donated pasteurized human breast milk, breast pump and breastfeeding and lactation supports and lactation specialists. There's been a flurry of laws that have been passed that we are working to implement. So it's a very exciting time for us. And I really think it grew, the seeds came from our Title V work and our work with our Department of Health. So I hope that provides some sort of oversight into what's going on in our state.
Thanks, Tom. I think what you're really hitting on is that, the Title V informed Medicaid and Title V were able to work together on some of these specific things but I also think you will get to that part about obtaining approval in a little bit, but I think what you're pointing to is that the approval needed to come from the legislature a little bit to move some of that forward as well. Okay, we're going to keep going west. And so Dr. Kelly, if you're across the Delaware River there in the Susquehanna and Harrisburg, I don't know if you want to comment on how Medicaid and Title V have been working together just for a couple of minutes as we can learn from Pennsylvania.
Sure. Thanks, Jeff. And thanks so much for allowing me to share some of my ideas with everyone. Here in Pennsylvania, my philosophy is let's figure out a way where we can take Title V initiatives and figure out a way for Medicaid to pay for many of them. So over the last 15 or 16 years, we work very closely with our Title V program that is housed in a different department, a Department of Health. We're in the Department of Human Services, similar to New Jersey. We meet every other month with our Title V senior leadership, and we really try to make sure that our programs are dovetailing nicely with each other, that there's no overlap, and that we're really trying to leverage programs that make sense, that are evidence-based, and if we can move them over into Medicaid, either under EPSDT or other premises, we do that. We're a managed care state, so we basically operate under our 1915B and waivers. So a lot of what we do happens within managed care. So we do spend a lot of time, though, trying to work together, and I'll just throw out a couple of quick examples of some specifics. We've been able to develop our medical home program that now is probably 5 or 6 years in the making. But prior to that, the state of Pennsylvania actually had a medical home project that was Title V funded for practices that took care of children with special needs. And basically, long story short, we figured out a way. We developed a patient-centered medical home program, and actually we're paying for those services. We especially wanted to make sure that kids with special needs were included in those in patient-centered medical home program. One of the things we also added as a requirement for our patient-centered medical home program came directly from that previous Title V group, and that was that a family member needed to be part of the patient-centered medical home huddle team, or needed to be part of that practice team to advise them on what was actually happening. So that's something that we actually took right from the Title V funded program and made that a requirement. So that's a good example of how we took services that were previously funded under Title V and we really operationalized them under Medicaid. The other thing that we did recently, there had been some vent care management that was funded under Title V, and we said, no, Medicaid, most of these kids are Medicaid kids, we should be funding that, and we found a way to fund that through our managed care plans. They are required to have special needs units that are geared to kids, but also adults. And those managed care special needs units specifically are required to manage children with high needs or special needs. Included in that program, we measure, and I know there was a focus on measuring, so we take a look at some of these extremely complex kids, and we make sure that every year, we usually have about 300 of these kids that are transitioning as adults. When they turn 21, we want to make sure that they still have the services that they need. And so we transition them into one of our other waiver programs here within the state so that they don't lose those wraparound services. And I can say that before folks hit 21, I think we're 99, almost 100% of the time we're getting those kids plugged in, those now adults plugged into the services that they need to be plugged into. And again, we're just coordinating a lot of these activities with the Title V programs. We also have worked with Title V around lead screening. We now pay for lead screening basic investigations through Medicaid. And again, we put that into our state plan, and our managed care plans also pay for that. One of the things that we're doing around equity is with postpartum visits, prenatal visits, postpartum visits, and well child visits, especially in the first 15 months. We're actually we're actually doing a special health equity incentive for our managed care plans. And again, we cover 1.1 million kids, and we know from our data that our children of color in that first 15 months are not getting in for their well child visits compared to others. So we've put a special incentive in place for our managed care plans to close that gap, also the gap in postpartum care, as well as prenatal visits. So then lastly, we have developed a home visitation program that I'll say it's not exactly nurse-family partnership, but it's pretty close to that, where we've expanded that in that we're now requiring our managed care plans to pay for at least 2 home visitation visits after mom gets home. And that's not just for first-time moms, that it's for first-time moms and moms that have complex needs. So again, we're trying to take some things that may have in the past been paid for in other programs, and we're figuring out a way to leverage that within the Medicaid program. As far as social determinants of health, we're actually standing up a resource and referral tool that we're going to be making available statewide eventually. We're starting in one of our regions, and that tool will be available for providers, our MCOs, and our community-based organizations to link folks that have particular needs like housing insecurity, food insecurity, and it's a resource and referral tool through a competitive process. We selected Aunt Bertha as that tool, and we're going to stand that up, and we're actually going to use that tool to measure social determinants of health, and not just where, who has perhaps a need, but are they getting that need filled? And as far as social determinants of health go, the other thing that we've done in both, we have a maternity care bundle that we've rolled out, and our patient-centered medical home program, we're actually requiring our providers to screen for social determinants of health and to report those gaps using Z codes. So those are just some of the things that we're doing, working very closely with our Title V program. It's been a great collaboration with them over the years. Thanks.
David, before I let you go and move on to Ryan, can I just ask about the logistics of the collaboration? You said you meet like every other month or something. Is there like an ongoing staff conversation going on in between, or, could you just say a couple sentences about how that functions?
Yeah, so we meet with our Bureau Director and some of our division directors, and our Bureau of Managed Care meets with the division director and some of the, not just senior leadership, but a fair number of the Title V staff. We have those meetings, but there's interaction that goes on in between those meetings. So for instance, we, one of the Title V folks alerted us that one of our managed care plans was not appropriately paying for, let's say, certain types of genetic testing for cystic fibrosis. So they actually alerted us to that, and we handled that problem. There are other examples where they've alerted us, that some providers may have told them that, audiology services may not be as available in certain rural areas. So they're kind of the eyes and ears, the extra eyes and ears for us programmatically. So there are emails that come into us on a regular basis. So it's not just those, well, they used to be face-to-face meetings. It's not just those team meetings, but they're the emails that go on in between that I think are just as vitally important. And the staff underneath us, they're interacting probably even more than I know.
Great, thanks. There's one more quick question. California was just asking a little bit about, and I want to get this just really quickly. What's your incentive for well child visits to decrease the disparity?
So there's actually two things that we're doing. One is with our MCOs. They have 2% of their premium at, I won't say at risk, but it supplements their normal rates. So well child visits in the first 15 months is one of those measures. And we've identified, I think, about a 4 to 5% disparity gap between African-American and Caucasian well child visits in the first 15 months. So we actually are measuring using the HEDIS measure. We are measuring each plan specifically on those children that are African-American. And if they hit a certain benchmark and show incremental improvement, There are, I'll say probably, I don't know, probably a couple, depending on the plan, a couple $1 million involved in those incentives. Again, that's based on how many kids each of those plans have. So that just is an example. In our maternity bundle that we are just now rolling out, we actually, and our OBs didn't necessarily like this, but we're including in there the well child visits to look at in the first 15 months, whether or not there, at least the first 2 are occurring. So we want our OB community talking to our pediatric community. So we've built into that incentive program extra dollars if indeed they are closing that equity gap. Again, for the well child visits, and in that program, we're also doing prenatal and postpartum care. So we're giving them extra dollars. Those they're basically medical homes for pregnant women. They can earn extra dollars based on the closing those equity gaps around those measures. We're also giving them extra dollars based on doing some very basic screening for social determinants of health.
Thanks. I was always, go ahead.
I was just going to ask if that 2% with the managed, was that a 2% withhold with the managed care organizations that they can earn back?
No, it is. I want to be very clear. It is not a withhold. It's you know, it falls under the 5% above and beyond. And we chose, it's a 2% of the total premium. So it's, I think what's sitting out there is probably close to, I don't know, probably $500 million, 400 and some million dollars total across the entire program. So it's a significant chunk of change, even though it's 2%. So it's not a withhold. Those are extra dollars that they earn.
Great, thanks.
Dave, I'm always jealous of where you got that money from. I want to go down. Let's go down to Texas and have Ryan talk about how Medicaid and Title V interrelate in the Lone Star State. You there?
Thanks, Jeff. I feel like I should say howdy. I will admit there are 2 reasons I might need to step away. One is that our legislature is in session right now. In person, I might add, we meet every other year for 140 wonderful days, and our Senate Health and Human Services Committee is meeting now, and our state Medicaid director is going to be presenting. And the other thing is, because of the winter storm, I'm waiting for the plumber to come to the house to fix our water heater, which has been broken for although we were only without power for 36 hours and so fared quite well. I will share a quick story. So Jeff mentioned during the introduction that I've been engaged in Medicaid policy since I was a first-year medical student. And so just quickly, this was 2006. I was bright-eyed and bushy-tailed, wanting to take on the world and save kids. And CHIP, Children's Health Insurance Program, was up for reauthorization. And so I got down in front of my 200, member medical school class and talked about CHIP and why we should care. And then I decided to send out an email to the entire class using my medical school's email server, asking them to contact their elected official. And so the next day I got a phone call from the dean's office and was almost kicked out of medical school because I violated the medical school's acceptable use policy. The dean told me that he completely agreed with what I was trying to do. And so that was my first foray into Medicaid, and not that I had anything to do with it. CHIP was reauthorized in 2007. Texas Medicaid, we cover about 4.5 million lives, 3.7 million of which are children. We are the 3rd largest Medicaid program. We are 95+% managed care, 17 different managed care organizations, 3 dental maintenance organizations. And I bring that up because I think the majority of my comments today are going to be around collaborating not only with Title V, but with our managed care organizations. And so I'm pleased that we have some of our Title V staff that have joined us today for the call. I think the most important collaboration that we have is those informal emails and phone calls in a previous era, the meet and greets over lunch or coffee, just to share stories. And I think it came up before, alerting us to issues that they're hearing in Medicaid. in Texas, separate from Medicaid, our Title V group operates a separate program for children with special healthcare needs called Children with Special Healthcare Needs that do not qualify for Medicaid for whatever reason. And that program provides a Medicaid-like benefit for that subset of kids. And I've been a provider in that program as well as Medicaid for my entire career. And so we can strategize about that. Like my colleagues, our Title V lives in a separate agency. So we are all part of Texas Health and Human Services, which is about 40,000 staff. Our Department of State Health Services, which is the public health agency, is where our maternal and child health programs live, including Title V. And then Medicaid lives in the larger Health and Human Services Commission. And so the silo issue is very real. And I hope that my Title V colleagues on the call feel that we've broken down some of those silos. But the one example that I am most proud of and really can take zero credit for is a value-based payment pilot, we'll call it, or demonstration program at one of our complex care pediatric clinics here in Austin. And I know I'm, again, joined by some of those leaders today, Dr. Rahel Burhani being the medical director of that clinic. And it's through the Collaboration Improvement and Innovation Network program through HRSA. Actually started with Title V funding quite some time ago and has evolved. And what we're trying to do, so you have Medicaid, you have Title V, you have a frontline provider. One of the really unique aspects is we have family representatives. There's a great organization in Texas called Texas Parent to Parent. We have Maureen Benscoter on the call today from that group that helps actually educate medical students, but also provides advocacy and resources for families with children and youth with special healthcare needs. And we also have one of our managed care organizations that is very intimately involved. And we have Kevin Werwood from Blue Cross Blue Shield of Texas, who I know is participating. In Texas Medicaid, we have a product service line specifically for children with medical complexity. It's the Lone Star State, so we call all of these programs something. It's Star Kids. It covers 160,000 children with special healthcare needs. And in that program, the managed care organizations are contractually obligated to provide a higher level of service and care coordination. And what this pilot is all about is partnership between the medical home and the managed care organization's care coordination staff to make sure that everyone is swimming in the same direction, not duplicating efforts, involving the family, having concurrent visits with primary care and specialists. And we require an annual assessment and reassessment to be done by the managed care company to make sure that that individual is getting all medically necessary services, to include waiver services. And we are hoping that we can leverage the care staff in that clinic who has been caring for that child for many years to help with that assessment. And again, make sure everyone is swimming in the right direction, really engaging the family and the child in all of this work. And so I'm really excited to see where this is going to go. Value-based payment is huge in Texas Medicaid. We have actually set targets for all of our MCOs to where this year, 50% of all managed care organization payments to providers must be done in a value-based payment model, and 25%, so half of that 50%, must be in some type of a risk-based arrangement. And so lots of the really forward-thinking work in Texas Medicaid is happening in the value-based payment sphere. And this is what we're trying to do with this pilot. I'm really hopeful that once we continue to move forward and we have some best practices, that we will be able to share those with our smaller Texas communities. We have so many rural areas in Texas, and we know that there's smaller mom and pop practices that are taking care of kids with medical complexity too. And so is there an opportunity for us to share those best practices with those smaller frontline providers who are 200 miles away from the closest tertiary care children's hospital? And so I'm so thankful of the collaboration and partnership and really excited to see where it goes. I've only been in my role for 2 years and I'm still active in patient care. And so really this is just a really exciting culmination of all of this work. And it's really a thrill to be with y'all today. Thank you.
Great. Thanks, Ryan. I think Ryan's an example of somebody who brings energy and all of a sudden pushes things around to get change. So I always am it's very cool. Curtis, I know it's morning over there. And And it's, but I'd love to hear your perspective. You have been with the Medicaid Medical Directors for a long time and have been an advocate for working to improve the care of kids with special healthcare needs over in Hawaii.
Yeah, thanks, Jeff. Aloha and good morning. And it is morning out here. Jeff, I just want to verify the sound check. Is sound okay?
You sound good.
Okay, great. So before I start, I wanted to make a comment on Calcia. So Calcia was my professor as a med student 25 years ago, and then doing PEDS residency, my professor at the local hospital. And he really ingrained this kind of, in all that you do, don't forget about kids. And he would be happy that we're in these meetings now. And one of the first people that called me when I became Medicaid Medical Director was Calcia. And he called me, I went down, he said, hey, don't forget about the kids and all that you do. So he would be proud. He just passed away last year. So we'll continue the good work for Calcia. So in Hawaii, we are like New Jersey. Title V sits in Department of Health and we sit in Department of Human Services. So I think one of the really big challenges is how to cross those silos and connect those silos. And couple things that have been really helpful is one is you have to really make sure you have an EPSDT RN or nurse, and that position is really helpful. In Hawaii, we got dinged for not having one for several years, and that position is very helpful because in either that nurse or other nurses can sit on different committees, different state level committees that the DOH agencies are on. The other thing that's been really helpful is we have a monthly meeting called the EPSDT meeting. And in that meeting is mostly the DOH representatives. We have our side too, but it's one of the monthly meetings that really help connect us across the silos. The other thing that's been really helpful is not just connecting at the top between DOH Title V and Medicaid, but if you can connect in the middle. So if you have really good connection with the developmental disabilities group, early intervention group, in Hawaii, we have a carve out for seriously mentally ill children and child welfare services. So if you can connect in the middle really well, it's really, really helpful because often there's a disconnect between the administrators and kind of the real world. The other thing that's been really helpful in Hawaii is we pay for care coordination through fee-for-service for care coordination done at some of the DOH entities like early intervention through developmental disabilities. And one area that's been really confusing in crossing the silos is who does what. So for care coordination, service coordination, we have that under our managed care plans, and we have it under our Department of Health, all these Title V agencies, and who does what is confusing sometimes. So one of the things that's been really helpful in Hawaii is we came up with a grid that we did a Medicaid memo on, and we kind of really went into detail on, okay, what does the developmental disabilities case manager do? What would the MCO case manager do? And same with early intervention. And we kind of mapped it out. The other thing we did that was helpful is we designate who would be primary for case management or care coordination. So in certain populations, like if you're really sick, like your LTSS, then the managed care would be primary and early intervention would be secondary. Same with, and then similarly with DDD, who would be primary, who would be secondary was really helpful. The other really helpful thing is data. So honestly, when Department of Health or when different agencies call for data, and people always want data from Medicaid, our response is usually we can't do that because we're behind on our reports to CMS. So we, in fact, I think in other states you might have this. We have like a canned letter that says like we're unable to do these data pulls because we're we can't do these one-offs all the time. So data is really a key area that Title V agencies want from Medicaid. And it's not that we don't want to do it, but we're so behind on data ourselves that it's been hard to do. So I think one of the things I would recommend is for different Title V agencies, if you put your ask through the Department of Health, then it's more likely that Medicaid would do the data pull if it comes from a fellow state agency. The other thing is for data, the better ask is not, can you run this report for me? But the better ask is, what type of reports do you have already run? And then kind of look through those reports, because you might see helpful information through that area. And probably the last thing, Jeff, and maybe the most important thing, is that in the reports we collect from the managed care plans, the most important thing for the managed care plan is money. So when we collect data on the plans and we grade them on it, I don't know how important it is to the managed care plans, even the core set data that we collect, but what they really pay attention to is what's financial. So what data is a P for P for the plans is really key. So I would try to find that out, like what is a P for P with the plans in your state? And then one thing I would recommend is P for P is if you can allocate a certain amount of P for P, say like 50% as children's and women's health issues amongst the P for P, then that's really great. I think in Hawaii we hit like 40% of the P for P. The P for P measures are the most important measures to the managed care plans. So the other thing in Hawaii that we did was we escalated the amount of P for P each year. So I forgot what we started at, but we're going up by a percentage point every year. So that bucket in P for P is massive now in terms of money to the plans. And within P for P, how you pay the plans is really important. So one thing we did in Hawaii is we don't just pay whoever was the top plan for a marker, because when we did that, only one plan got the money every year, and it was the smallest plan. So we also pay off the delta. Like if your baseline was low, you had a sick population and you hit a delta, then you get a P for P. So each plan now is chasing each marker. So that's been really helpful in Hawaii. And that's it. That's the overview on my end. Thanks, Jeff.
Curtis, thanks. I have to say that the paying off the delta versus paying off hitting a certain level, I feel like is what pediatricians advise parents about. You know, do you encourage your kids when they are making progress, or do you encourage them only if they hit a line? But I think it's so kids and MCOs, they're together there. But I and I also want to just add, I want to highlight something you said that I think is super important, that this group I think has worked with a lot, is around who is primary for care coordination, and the fact that you have a matrix to do that I think is really interesting. I want to turn this back over to Ellen Marie, and I know that some of our panelists may have to come and go a little bit for all the reasons that they said, but Ellen Marie, can I turn this back over to you to just talk about moving from the Medicaid Title V to talking more in the Medicaid weeds around getting approval for services and then implementation?
Jeff, before we do that, can I ask a question of Dr. Toma? And then I wonder if, since we're going to be moving away from the integration of Medicaid and Title V, if we wanted to, if there was any other questions that folks wanted to ask about that integration. But for Dr. Toma, one of the things that I think is really important, and I think you're not alone in Hawaii, is how to better use Medicaid data. And we are excited about the advances that we've been making in Medicaid data. Before, every Medicaid agency, and there's 56 of them with the territories, collected data separately, reported it differently to us, and it was the only way to do any kind of evaluation or monitoring was to do it individually, state by state. About 10 years ago, maybe more now, we embarked on having a reorganization of our data. TMSIS, which is the Transformed Medicaid Statistical Information System, TMSIS, is now our system where all 56 programs report the same data the same way, so we can look across states. And all the states are reporting to us. We then make those data available to researchers, and we're always looking for opportunities to talk more about this to researchers, because I'm a recovering health services researcher, and I'm envious of what we've been able to learn from Medicare, and now we've got those Medicaid data out there. So all the states are reporting it to us, so we know it's out there. And so, Dr. Toma, it was interesting to hear, and again, I'm sure you're not alone, is how we get those data to the folks within the states that need it, to clinicians. I was at the Innovation Center before I came over to CMS Medicaid, and as a clinician myself, getting that information to me would help me do a better job figuring out how to design my practice and perhaps make real-time decisions and quality improvement, but also getting those data to the other entities across the state who might be able to use it. And you noted that seeing what kinds of reports are already done, but I think then looking forward to see what other data could you use or would you need. So can you talk a little bit more about some of the challenges that you've had, because I'm sure it will resonate with other folks, and any successes that you've had using those data?
Yeah, I do think that getting the word out on what data is already available is really, really helpful, because it's, I think even at my level, I'm not sure what data is readily accessible and what can be shared with the public. But I think each state also has different data analytics capability. Some states have a lot more robust data ability than say ours. So sometimes when we say, hey, in this state we're getting this data, in this state we're not getting this data, some of it may not be that the states are being evasive. Some may be the true capacity of the states vary, in what they can get out. But I think that, for Medicaid, we certainly want to get the message out that we're not trying to be evasive on data, but data is a really big challenge in our state, to kind of keep up with reports and things. So we do get a lot of requests from individual entities, individual kind of groups that are kind of, hey, can you run this report for us? That would be very, very difficult to do. So I think the more the request is kind of aggregated up, like say a DOH silo, then the more meaningful the ask would be over.
Great.
Jeff, maybe we put that on a future to-do meeting, is exploring folks. We just did a panel at Academy Health Data Palooza, which is a big conference for health services researchers, on what data is available. We're trying to get the word. We've worked with the Maternal Child Health Bureau to get those data in the hands of pediatric researchers. So while a lot of the focus is on research, there's also ways to use the data for monitoring, and that might be something to explore, because ultimately my wish list is then, once we do a better job actually understanding the Medicaid data itself, if we really are looking at social issues, the next is to start to link those data, those Medicaid data, with other social service agencies. And I think that since an intervention in one silo sometimes has the improvement in another silo, if you will, well, we ultimately can link those. And there are states that are doing some interesting work linking with WIC, linking with SNAP, so that you can track individuals and seeing what kinds of services they're getting. So thank you for providing a little more information. And I think part of what we're doing today is better understanding what kinds of information this group might need to further sustain their work. So maybe before we move to the Medicaid and Title V, are there any other questions about kind of this coordination between the two programs? Because I think where we're going to go next might have less to do with kind of that integration. And I've been trying to track the questions there too.
Ellen Marie, this is Rich Antonelli. I'd like to have you and the panelists, as necessary, really dig in a little bit more deeply to this notion of value. And Michael Warren mentioned this before, but value for whom? I've had the privilege of sitting in many conversations around accountable care organizations, and we're seriously trying to think about the social determinants of health, because on the one hand, being in stable housing will definitely impact ED utilization for the non-clinicians, emergency department utilization. But I'm just wondering, what are the immediate opportunities for alignment between Medicaid programs, CMS specifically, and the state Title V programs to really dig into this notion of value-based care? There are implications for when we get down to number 4 on the panel around measurement, but that's why I wanted to bring it in at the top of the conversation. So a few words about value for whom, and how do we actually reconcile any discrepancies?
So great question, value for whom. Let me step back and kind of talk about where we are in terms of value-based care. And I saw that there was a comment earlier about why Medicaid was stuck in fee-for-service. And I can tell you it's not for lack of trying, but it's difficult, right? As I've said to so many of the folks we work with, if any of this was easy, it would have been done before. You are all at the forefront of trying to figure out how to do what has been a difficult thing. And I think, as Dr. Warren pointed out, not only what we measure gets improved, but also what we pay for. So in a fee-for-service system, we just do more services, and that's what gets the notification. So we are trying, we being Medicaid, we being all of CMS, and again, I started at CMS in the Innovation Center to try to figure out ways to facilitate providers, clinicians, to move from value-based care from fee-for-service to a value-based care. And I will get to your for whom, Rich, because I think it's an important one. I'm not sure I have a great answer, but I think that's really important. So the movement to value-based care started with Medicare because it's easier with Medicare. We pay the same for every service that's provided across the nation. In Medicaid, we started, and I saw someone in the comments mentioned paying for centering and paying for group care. And one of the things I worked on when I was at the Innovation Center was a model called Strong Start, which was the very first Medicaid model at the Innovation Center that looked at outcome. The outcome was prematurity, which is a pretty tough nut to crack. That's a tough outcome, and better understanding different pathways that might improve, decrease numbers, the prematurity rates, while also being cost effective. And I think many of you know that cost effectiveness is something we could do a better job. I also am very cognizant, especially in Medicaid, when we're talking about value-based care, that doesn't mean paying less, because Medicaid already underfunds, and we know that. So we don't want to get into a position of saying we need to put less dollars in. In the Innovation Center, there are 3 ways to establish success. The primary is less costs and improved quality. They also determine it's successful if it's less effective, if the effectiveness is the same and they save money. But the third, and I always say the most important for Medicaid, is if the quality improves, well, we don't increase the cost. So can we at least stay neutral, or have those funds, then the savings come back in and reimburse the interventions that we're doing. So again, we had spent a lot of time on Medicare. We now have 2 models, and at 2 other models at CMMI that are focused on maternal child health. You all know about the INC model, since some of the states are part of the Integrating Care for Kids, or INC model, which is a pediatric model. And then we also have the maternal opioid misuse model, which we have, I think 9 states are participating in that. And they are looking for the outcomes of the beneficiaries. Payment will be based on improved outcomes. So is that the value that the beneficiaries that we're measuring then, because that's so limited, we've been looking for other ways to work with states. And states can always come to us with an idea that they have on how they want to do a better job doing value-based care. We then work with the state to figure out, and we'll talk about this a little bit in the implementation period, how they can get to yes. We have to approve the paths forward, but we work with them to figure out how we can approve what it is they want to do. And within that process, we look to see what's the best path forward. The most simple is amending their state plan, a state plan amendment, or a SPA. Another very successful way, and you heard David talk about that in Pennsylvania, is amending your managed care contracts. And I think that's probably a benefit that a lot of folks here might be able to figure out. And Pennsylvania has done a remarkable job, I think, looking to see how they want their program run, and then working with the managed care plans, putting language in those contracts to be able to move that forward. And we can talk a little bit about this later, but I think sharing what that language in the contract looks like, to the extent that it's legal, is something that could be really helpful to share across all of the awardees here. That's not something you would need to necessarily figure out on your own, but use these learning collaboratives. I'm a big fan of these learning collaboratives, and what is it that you can share amongst yourselves so you don't have to kind of go back to square one. So we have the couple models at the Innovation Center. We have different states that have come to us and asked for ways to move forward. Washington State, Oregon, Massachusetts, many of the states, I'm not even sure who else is on the call, but we've been able to approve either really large processes for moving forward or some more targeted ones. Since there was some confusion on how to do that, we released, and we can put a link in the chat box, a letter to state Medicaid directors on what are all the tools in the toolkit that you could use to be able to move forward in value-based care. And it started out as kind of a limited letter. It took us about 2 years to get it out. And it's now almost a primer on what is value-based care. And part of my intent as we were writing this, although it's directed to state Medicaid agencies, in my 6 years of being here at CMS, it has been not surprising, but kind of an aha and a reminder that many clinicians don't know what Medicaid can do. Advocates don't know, families don't know. And unless a larger proportion of folks, instead of just the state Medicaid agencies, know, we need that larger force to be able to say, this is something I want our state to do. We may need to go to our state legislature because while Medicaid is a federal state match for funding, the majority of the funds come from the federal government, but you states still need to get those extra dollars for the match. And often it needs to go through state legislature. So the more that folks know about this, so we're trying to promote this letter that we did on value-based care. As we were writing this letter on value-based care, I certainly was one of the strong proponents of reminding folks that we cannot improve outcomes in just the clinical setting. We have to look at what the social issues are. And it wasn't so long ago, the federal government would never have been talking about social determinants of health, especially CMS. And the fact that we actually are talking about this now, I think is a huge step forward. And it's also an acknowledgement that Medicaid is more than just an insurer. Medicaid is called medical assistance for a reason. Medicaid has long reimbursed for non-emergency transportation. There are some instances where housing can be covered. There are some instances where food can be covered for specific populations. You know, this is not everyone gets Blue Apron, but there are ways and individuals that maybe can be eligible. And again, many of those are options for states, not requirements for states. And because a state isn't doing it doesn't mean they may not in the future if they're given the right impetus to do that. So after we published, and we published in September this letter on what states could do in their toolkit about value-based care, we then did what I refer to as the sister letter on here are the things in the toolkit that states can do to look at the social determinants of health. And hopefully there we're getting to a wider array of what value is and acknowledging that you need to get the transportation to where you need to go. Perhaps if we're looking for individuals, this is mostly adults with disabilities, but going from an institution to more home-based settings, there are supports that we can provide to individuals to get them into the home. And I think that your question about who the value is for, we would say we hope the ultimate value is for the beneficiary who is able to better access, better care. It ultimately is more affordable. We hope that the state can ultimately make this happen without pouring a lot more dollars into it. We understand that Medicaid is a huge part of the budget for all states. And unfortunately, if we pay more Medicaid, sometimes it means there's less things that the state can fund otherwise. So we hope that that benefit is to a broader population there too. And then as we're exploring into the value-based care, a broader swath of what it is. I will throw out another question that I ask, and I think we don't have an answer for yet, but it's on my wish list, is when we talk about total cost of care, and we pay for a total cost of care model, like a fully capitated model, the total cost of care is the care in the healthcare delivery system. But especially in pediatrics, and I'm a pediatric clinician by training, the total cost of care might include schools, might include food, might include these other things. Right now, when we look at savings, we only can look at savings right back in the healthcare sector. But ultimately, if we do a better job in healthcare and we know that that helps early intervention, that helps schools, that helps kids, that helps decrease mental health, which could be ultimately criminal justice issues. Ultimately, I just like to flag that while we talk about total cost of care now, that should be something I think that we look at in the future. Wow. Let me stop there because I really do want this to be an integration, a conversation across our panelists as well as our audience.
Elmarie, I just want to make two quick comments about that. This is wonderful. And I think a lot of us are pretty jazzed up about thinking about that, and something you said earlier, which was around, we may need a whole separate conversation around how to put the data together. I think I want to just honor one thing in the middle of this, is that some of the families and the communities of color are really, I think, essential to talking about how we define the quality and what we put into the total cost of care equation. So we, I think, have had some great experience making sure they're incorporated into that as well. So I just wanted to make that comment really quickly. Rich or others, are there any other comments about we could spend easily the whole time talking about the Medicaid Title V relationship here, but I want to make sure we're not missing anything. I think the one other thing, Ellen Marie, that I don't know if any of the panelists want to address is we got two questions, one from Medicaid, one from Texas and one from Montana, and they kind of overlap. The Texas comment was around medical neighborhoods, community schools, integration, which I think is really some of the things you hit on, but I want to make sure the panelists, if they want to react to it, they can. And then the Montana comment was around how the COVID flexibilities have supported kids with special health care needs and equity. And probably a follow-up of that would be where do people see that going after maybe if we're lucky in the summer after the pandemic starts to fade? I don't know if anybody wants to further talk about those things specifically.
I'd like to generally talk about the flexibilities that were offered, especially with regards to telehealth. I don't know if there's been any determinations that have been made in a preliminary sense, but I think that would have tremendous benefit to us for individuals that have difficulty in traveling and have difficulty in accessing services. The relaxations of the security requirements and other things, I think, personally, I can't speak for the state, but personally, I'd be very interested to see if those relaxations could be extended beyond the PHE, because I think there's tremendous benefit to that. I don't know if that's where you're going, Jeff, but it's a related issue that I'm thinking about.
Yeah, I think where I was going was really kind of trying to tap you guys to see if you or your states are thinking about, and I think the answer is simply yes, but the fact that people are thinking about telehealth and the flexibility it provides for children with special health care needs. And I'll just make one other comment that I've heard along the line here as the Medicaid medical directors have been writing a policy paper around telehealth, was the idea that some things are better done in telehealth. And one of those could be some of the aspects of care coordination for children with special health care needs, because it gives people, it's not an episodic visit where you just do all of that, but it's sort of an interval where you take care of the needs, and it may be broader and deeper in terms of being able to identify social risk factors and address those as well.
This is Ryan. I can weigh in on that. So I agree that the telehealth flexibilities have been absolutely critical. Going back to service and care coordination. So again, in our Star Kids program, for the lowest tier of complexity, the MCOs must do quarterly, previously face-to-face visits with families to make sure that those children were getting medically necessary services. And we have, of course, allowed that to be done via audio plus visual, telehealth, or telephone only. And I think the anecdotal information we've received is the service coordinators really, really like that. And families really, really like that. It's convenient. Someone doesn't have to take an entire day off of work. It's really been beneficial for lots of folks. I think that the challenge going to equity is we know that there's still a subset of families that are not able to be reached via telehealth. They don't have broadband, they don't have a smart device. And so we've been really gently nudging our MCOs to help bridge that digital divide. It needs to be more than just letting the family know who the internet service provider is in their area, but whether that's delivering a smart device for them with a mobile hotspot to allow them to do that annual assessment that is so critically important, for example, for them to qualify for certain waiver services. And so we've always been thinking about equity and these flexibilities. We also want to make sure that member choice is respected. So if that family really feels like it needs to be in person, we should allow that to happen with with the appropriate precautions taken. And of course, there's going to be those situations where at the end of the day, the clinician in me says, there are just certain things that you just can't do via telehealth. It's just not clinically appropriate. I think visualizing the home setting and being physically present is so important for these families. Again, getting at social determinants, seeing that the plumbing in the bathroom doesn't work. And again, that's hard to come across with telehealth. And I also want to riff on, thinking about social determinants. And I think Dr. Whalen, you mentioned the need to connect with other agencies and services. And I think the partnership between Title V and Medicaid is really natural, but I feel that Medicaid can't take on social determinants for this very vulnerable population on its own. And I know we were talking about budget constraints. It's a third to a quarter of the entire state of Texas budget. And so, I think partnering with our Department of Family and Protective Services, there was a shout out to WIC, to SNAP, to housing agencies and workforce employment. We need to figure out how to leverage those other entities and, of course, community-based organizations to really serve these families better, because they certainly are more vulnerable.
Great.
Jeff, I'll just flag that much of the flexibilities that Medicaid now can pay for telehealth services were available before the public health. Medicare did not pay for it. So the federal government allowed a lot of flexibilities, but a lot of those telehealth flexibilities were options that states could have had before the public health emergency, and they acted on them now. So it'll be important to make sure that if you've thought that this was helpful to you, make sure that your state Medicaid agencies know that, make sure your legislation knows that, because they will likely have the opportunity for many of these things to be able to enact it on their own without our approval even, as they move forward. So just making sure that where it's helpful, make sure that the folks in your state know that you have found it helpful, and let the families, and I know we've got families on the phone too, if you have found these services to be helpful, make sure that you let your folks in your state know about that.
Great. One more quick thing about telehealth. I just want to honor the fact that I think it was Ryan and Ann Zier from Indiana who was on the call, were the primary authors of this policy brief that the Medicaid medical directors are working on this. So cool. I'm wondering, since there's so many great places this conversation is going, but I wonder if we should move on to our second set of questions, just so people on this group can talk a little bit more, learn a little bit more about how Medicaid works. And I think, Elmer, you already talked about some of the options for the vehicles at the federal level, and obviously the state level, the state plan amendment contracts, and waivers. But I wonder if we want to get into a little bit more about how the Medicaid operation side of things.
And let me just kick it off, and then I'd really like to hear from the medical directors. One of the things that I think is really important in general with value-based care, and I think really important in Medicaid, is to make sure that we don't say, here's the payment model, and then hope that the care delivery model will follow. Payment model should support what we think is the best care delivery model. And sometimes in Medicare, we did a shared savings approach, and then we just hoped that and in fact, most times it happened, that folks would then figure out how to do the care delivery model because they now had a shared savings model, or because they now have a bundled payment, they would back into changing the care delivery model because of the payment model. And I think it's really important, especially for the kids with special healthcare needs, pediatrics generally, Medicaid, is identify what the right model of care is, and then identify how we can get that supported. And I think I'm probably speaking to the choir here. You've been spending years figuring out what your care coordination model is, and then how that gets paid for might be different across different settings. So kind of that obtaining approval is basically, what is the idea that you want to continue, and how do we then start to think about what that payment model should look like that will keep that care delivery model going. So Jeff, I know you've got some questions that you have outlined there. I don't know whether, do our panelists have that set of questions too? Do we want to kind of specifically?
They don't have they have the topic, but not the details.
Okay.
So
I guess maybe even just to think about, and it sounds like all of you have had some success in your states figuring out how to sustain, how to pay for some programs that you've had going on. What would be some of the first things that you might do to try to get this, get a payment model approved, or get it in front of the state Medicaid agency so that they can start to think about how we get that? Do you have to go to the legislature? Does it need to be budget neutral? How do you get that process even started? And we'll open it up to all of the panelists to see if they have initial thoughts there.
I'll ask if they want to. we could go back, we could bounce back from Hawaii towards the East Coast. Curtis, do you want to talk about that, about how services get approved in Hawaii Medicaid?
Yeah, Jeff, honestly, I'm not sure of the details of how it gets approved, but I do know that in our RFPs, we put benchmarks for the MCOs in terms of like what percentage of your patients need to, or providers need to be PCMH. We also put like a percentage markers, and I forget the percentage, like so much percent of your contract should be value-based payment. But Jeff, I did want to comment, that the health plans themselves, or MCOs themselves, have went ahead with value-based payment with their providers separate from the Medicaid office. So in Hawaii, the largest commercial and largest Medicaid payer, they went ahead and did value-based payment with the individual docs. And it was kind of a one-way discussion, because in Hawaii, we have so many independents. Majority of our docs are independent. So there's a kind of power mismatch. And what the health plan said was, we're just going to pay you a PMPM for all your patients. So this is between an MCO and a provider now. And then so the docs have a PMPM, flat PMPM for the patients. So the flip side to that, though, is the flip side to quality is access. Yeah. So now our sicker patients are having a hard time accessing PCPs. So over.
Wow. Do you monitor that outcome, that either the access issue or their contracts with your MCOs, then feed the feedback to them whether they're meeting access goals?
Yeah, it's been really hard to track. We get anecdotal complaints from the individual docs and the patients, but it's been hard to kind of monitor access from a state level. I think the default is some of the patients, sicker patients, are moving to the FQHCs because they can't say no, right? You just kind of put them there. Over.
Got it.
Jeff, a couple of the things that I heard when we went through in the beginning, it was great to hear that in New Jersey you're moving forward with doulas, and I was wondering how they were paid, and so Dr. Lind, and then also Pennsylvania has been a leader, I think, in working with their managed care organizations and the contract language. There were a number of things that Dr. Kelly mentioned that they then, the state worked with the managed care plans and kind of required the managed care plans to do certain things. Some of that the states can do on their own. We also have a process, which I won't get into the details, but a state directed payment, we call it, where we work with the state to come up with language on what they can require the managed care plans to do. So I don't know whether Dr. Lind or Dr. Kelly want to talk about kind of how you move forward getting those new services either just paid for or as part of the managed care contracts.
Yeah, in the state, we came up with, it was a pretty laborious process coming up with a fee schedule for doulas. They needed to fit into the right niche between competing provider groups to make sure that they were being appropriately reimbursed and that it was a living wage and they would be able to continue that. One thing we were able to work into our doula wage structure. So the state established one, and then we mandated, we're also a we're also a managed care state, over 95% managed care. And we imposed that fee schedule upon the MCOs. We did build an incentive that is a one-time payment for an initial postpartum visit with an OB, so that if that visit occurs, then the doula would actually be incentivized for that coordination of care. So we do have some sort of quality measures that we built into our doula rate structure, and those were very thoughtfully implemented and with a good deal of stakeholder input.
Thank you for that.
Yeah, Tom, that's really cool that I think one of the things you said that just kind of was a sentence that you imposed the fee schedule on the MCOs, which I thought was really kind of interesting, because I think that's, one of the things that I've learned from a lot of folks in this academy is people's willingness or unwillingness or states to get into that kind of detail in the contract. But I think that obviously made a difference for the livability for the doulas for if 95% of folks are in managed care. Elmer, you were directing your question also at Dave. I don't know if Dave, you want to comment on some of the way in which services have been approved over there.
We don't want to call him out if.
Dave might have hopped off. I'm not sure if he's still with us.
Yeah, he's listed as being here, but maybe he's trying
The
to.
other thing we heard from Texas is Dr. Van Ramscher talked about this value-based purchasing pilot that you have started, that you brought together a number of stakeholders. So maybe talk about how that process got started and how you kind of got it in front of the Medicaid agencies to think it was something that was worth paying for before we actually got to the point of paying for it.
Thanks. I think this is best described as it was a grassroots effort. I think you had the clinical leadership of this really center of excellence comprehensive care clinic. You had parents, caregivers, and families that came together. This is part of a larger children's health system and said, we need to find a way to do care coordination better, to really support the medical home concept. And the Medicaid agency has been part of those discussions, kind of listening in and seeing and being present, as have our Title V partners. But I give, the clinical folks and the families a whole lot of credit, and they took it upon themselves to form a really positive working relationship with the managed care organization that's been a key driver here. And then kind of the three of those groups came to Medicaid and said, how can we work with you to make this happen? And so it's taken a little bit longer than everybody would hope. And I would say that at least in Texas, and I included the links to our publicly available uniform managed care contract and the managed care manual, the MCOs have tremendous latitude to develop alternative payment models, be them shared savings, pay for quality, and additional per member per month for providers that see a lot of kids with special needs. And so that's already there. It's a little bit of a double-edged sword because that means that there's plenty of room for innovation, but there's some plans that are perhaps less provider-centric than I would hope they would be, where it's more of a, here's the three things we're offering in an alternative payment model, and if you don't like these, I'm sorry. We have other really high-performing plans that are really partnering with families and providers to say, how can we help you find meaningful outcomes? And I'm so glad that a lot of the discussion this morning or this afternoon has revolved around finding meaningful metrics for families. Not did you have a prescription for a controller medication if you have persistent asthma, but how many days could Billy go to soccer practice because his asthma has been controlled? And like I said, I give a lot of credit to the clinic, to the families, and to the MCO in this circumstance. I think some of the operational things that we're trying to work through is not so much, I think, direction that we might have received previously from our federal partners, but working with our Office of the Inspector General to make sure that the correct forms that are in statute or policy are still completed. So again, in the example of that annual assessment, that is normally completed by the registered nurse service coordinator who works for the MCO. And so if we know that the nurse care manager for that clinic is doing that work, we need to make sure that that is still filled out, it's done appropriately, there's no duplication, but the Inspector General is not going to come back in a year or two and say, hey, you didn't follow what is outlined in policy. And so I think our next steps are really identifying those very specific policy things that we need to waive or be more flexible. And I saw one of the comments from one of my colleagues in Texas, and I'll call this out, that we need to make sure that the policies from the past, from that older fee-for-service model, are not hampering innovation moving forward. And so the Medicaid agency, which I'm a part of, will be looking again to those same three parties to help us identify those specific things which we need to get rid of or waive or makes more flexible so they can continue to innovate and we are not being a barrier.
Ryan, did you need new dollars for this? Or is it just a reorganization of care that was already being, of care services that are being delivered some way differently?
So it's a little bit of both. So this model, like I said in my introductory remarks, I think I remembered to say this, is it was initially funded by some Title V money. We've had some HRSA funding, and a lot of that has gone to support, some of the administrative time and also help support family participation in this work as well. And I'm really proud that we were able to support families to give them the flexibility to prioritize this. But there hasn't been, to my knowledge, an additional funding stream or infusion of funding to really anybody. You know, again, the MCOs are paid that capitation rate, and they have the flexibility to create these payment models, add value-added services, cover things on a case-by-case basis. And so they have that flexibility. And again, in this example, I think everyone is really trying to use that latitude to march in the same direction.
So that's really helpful. And I just want to kind of point out that the path that Texas is taking, which is the path that a lot of states take, is kind of letting the state Medicaid, the managed care plans know what we want these outcomes to be, knowing that the managed care plans do have lots of flexibility, and kind of expecting them to come to the table and figure that out. And many of them do. I think, and I don't want to speak for Pennsylvania, but I know there are a number of states that I think probably like in New Jersey, where you're a little bit more prescriptive. You told the managed care plans, here's what I want you to pay, or you need to pay the doula. In Pennsylvania, we talked about telling the managed care plans that you will draw down these additional dollars if and only if you meet these certain things. So states can be a little bit more prescriptive. They have that authority to be able to tell the managed care plans, here's the things we want you to include, and you can actually write it into your contract. And the details of how specific is a wide range. And I think that could be something that this group can talk about in the future, maybe at breakout sessions. What is the path forward? And every state has a different plan of how they want to do it. Texas wants to make sure that that flexibility is there, that the managed care plans can do it a little bit differently. Some might be a little bit more prescriptive there. And so I think that's a lesson that you really have to better understand how your state works. And Ryan, it sounds like one of the best things they did was this group came to manage the Medicaid. And I love the way you said, how do we make this happen? He didn't say, can we? Like we realize here is a new path forward. And I think one of the other things I'd ask is, did you have to convince them? Did you have to demonstrate for them, here are the outcomes we think we can achieve? And I think if you did, one thing that would be, again, important to be able to share amongst all of the participants here is, what's the language you used? Was it a cost effectiveness? Was it outcomes that you showed? What was it that you used to make your case, to kind of get it on the radar? And when that was successful, how do we share that language across all the different participants here to be able to perhaps reproduce that at home?
So I'm not going to comment on the specific language because I definitely don't have that off the top of my head.
Yeah, right.
But in terms of, the outcomes, I mean, we have set outcomes for our pay for quality program that we hold the MCOs accountable for. And we have specific pay for quality metrics that are specific to this STAR Kids children with medical complexity population. And they're good, but again, they're not really getting at that. What does this mean for the health and well-being and quality of life for my child? And so some of the discussions we've had is, hey, state Medicaid agency in Texas, can we work with you to create some more meaningful metrics? And I think the other element here is, a provider is likely going to be contracting with 4, 5 different MCOs at once. And so there is a tremendous need for alignment with these metrics, not specific to the children with special healthcare needs population, but across the board. So, with Health Plan X, they're doing a bunch of stuff with asthma. Health Plan Y is doing stuff with ADHD, and I can barely keep up. And so I think one of the roles for our agency is to help these folks articulate the vision. What are the metrics that we're marching towards? And of course, look to the core set, look to other sources, but really find meaningful metrics that we can all use, so we're not creating additional administrative burden for the provider and by extension, the family.
I think that was really important, that you had to come and help them see the vision. And that's not always so easy to do. First, getting on the radar and then demonstrating. I know Medicaid directors have said to us, if we funded everything that someone said was going to improve care, we'd be all over the place. So you really have to make that argument. And I think that's what you've been spending, this group has been spending 4 years, I think, figuring that out. And now how to synthesize that in a way that is, it can't be a 28-page report, right? There has to be visuals, there has to be charts, and it has to be kind of, let me get you engaged, and then I can follow up with the details. I worked on Capitol Hill for a while. I was in the Senate, and I used to always refer back to the saying that, I apologize for the length of this letter. I didn't have time to write a short one. You know, in order to get in front of these folks, it has to be short, it has to have a top line, and it has to talk about how the beneficiaries will be improved, how the patients in Texas and New Jersey and Hawaii, how are they going to be better because of the work that you're doing? And you all know this, but I think getting it in the communication piece, which I think is another thing, I keep going back to the beauty of this learning collaborative, this CoIIN, is that you can share that where there's been successes, so you don't have to all start from scratch.
Two other quick things. I think this articulation of the vision is definitely a two-way street. I know that transitions have come up in this call, and that has been something that this group and many other stakeholders have put on our radar and said, hey, state Medicaid agency, you don't have any really great transitions of care metrics. How can we address this? What can we do? And of course, we're thinking about, again, harnessing alternative payment models to look at care transitions. But you know, this has been brought to our attention. We need to have better metrics and meaningful outcomes for how we're doing transitions of care work. And I am blanking on the second thing that I was going to say.
Hey, I want to, while you're thinking, Ryan, I just wanted to bring up a couple things. First, I want to honor Ivy Goldstein's comment that some of the work that got started, that you were talking about, got started through Title V seed money. The other thing I want to say is that this relationship between the families, the providers, the MCOs, and the Medicaid is really what you've been able to do there. And I know Dave has been able to do, and I think everybody, the other Curtis and Tom as well, is to create a really functional relationship around making something happen that means something to the families. And, you know, your comments about can Billy go to soccer practice, I think is super relevant, because no provider I've ever talked to gets up and jumps up and down about the core measures, but they do jump up and down about whether their kids with asthma can get to go to soccer practice. So I think that the translation that I think, you know, Ellen Marie and I have talked about a lot, and I think we've spent a lot of time talking about in this academy and at MMDs, the translation of federal policy and state policy to the local level is where the rubber meets the road. And I think everybody here is talking about examples of making that happen, which is really what jazzes me up, because in the end, it's the example you stick to and make happen and get implemented in your Medicaid program and measure that makes a difference in outcomes. So that's really cool. Now, did you think about what you wanted to say?
I did, and I am certainly jazzed up about this as well, if you couldn't tell. And so, you know, Dr. Whalen, you were touching upon this letter that you would use to convince folks. I think what it was that was presented to our leadership is Dr. Burhani, so the medical director of this clinic, worked with families and her nursing staff to come up with a pictorial representation of all of the touch points, be it an authorization for speech therapy 1 week, and then the authorization for private duty nursing comes in another week. There's a phone call to family because Johnny had a fever. There's a follow-up after hospital discharge. And it was so powerful to see how many touch points occur for one of these children in one calendar year. And then think of how much of that is not really supported. There's no additional reimbursement to the provider. There's no additional support provided to the family as much as we try. And then thinking of the administrative burden on the MCO as well, that none of this is lined up. And so I think that was very powerful and impactful to see that and think that is one child. And it was over, I think, 200 touch points in a year. And it was far more convincing than certainly any letter that I could ever articulate. But Dr. Burhani and her team deserve a lot of credit for that, because it was certainly impactful for me. And I'm used to this because I'm still taking care of patients, but it was really well done.
And that's probably something you can share with the other states here, right?
I will make sure that I'll see where that is, but I'm sure Dr. Burhani is definitely the person that would be willing to share that if she's able to at this point.
Kara Coleman's on this call too, and she has advocated for a care map. I'm not sure who the author is, but it's very similar to what you're saying. Ryan, who saw that? Where did that go that it made an impact?
So it certainly went to our executive level leadership to include our state Medicaid director at the time, me and my co-medical directors, our deputy commissioner for policy, really, really powerful. And I think also to the managed care organization that has really, partnered here. I think it was really impactful for them too, because again, they've got staff that are involved in most of these touch points as well. And how can we, again, my favorite word, innovation is one of my favorite Medicaid words. The next one is alignment.
Great. Ellen Marie, we're kind of working our way through this, sort of the approval and implementation at the same time, but I just, and Ryan, it's really cool to hear your stuff. And I think we've talked a little bit about how it's been done in the past. I wonder if we want to ask some of the Medicaid leaders if, what they think are the next steps in that. And I think Tom had to step off for a minute. I got a BRB, which means be right back, I believe.
Well, and Jeff, when we were talking before, the implementation we were thinking, and I think we've integrated these two concepts now, is once we get an idea, and I think Ryan talked about it too, that once you get this idea of what you want to do, how it gets implemented in Texas, it's allowing it's acknowledging that the managed care plans have lots of flexibility and acknowledging that that's the way that we think that is next going to be covered. In some instances, it's a state plan amendment change. So an example there is our health homes. Health homes will pay a 90-10 match for certain services in a hyper, I think the folks who work on it at CMS Medicaid call it a health home, a medical home on steroids. So an extra way of doing some care coordination. And that's a state plan amendment change, which is something, none of these are super easy, but you work with Medicaid, and we can help get something like that approved for you. There are ideas that are not necessarily something that we have thought to cover or covered in a certain way. But if we think that it meets the outcomes of what Medicaid is meant to do, we work with states to do an 1115 demonstration. An 1115 demonstration is a bit of a larger process. We ask in that process for the Medicaid agency to do an evaluation of what that new idea is. And so that's another way. So once we get that idea and the state's on board and the families are on board and the clinicians are on board and we want to make this happen, the next thing is to figure out what are the mechanisms, what are the authorities that we have in place that allow you to get that happen, that allow the payment to occur there. So one of the things is for all of, I think, the participants, and I'm sure many of you know this already, is a real understanding of how things get paid in your state right now. Texas and New Jersey both said that 95% of the care is covered by managed care. That's not unusual. I think 2/3 of our Medicaid beneficiaries across the country are covered by managed care. But if in your state, Connecticut is an example, there is not managed care, then figuring out what's the paths forward. The other is understanding what kinds of new programs or new ideas, the strategies of a state, what their strategic plans are, and how what you're doing might align with what their strategic plans. So doing a little bit of homework and making sure that your state you understand what the state Medicaid's priorities are, as a few folks I think have noted, is that sometimes changes with administrations, as we're seeing now at the federal level, making sure that you better understand what goals your state Medicaid agency has, what their strategic priorities are, what the strategic plan is, and how what you want to do fits in with that. I just saw yesterday that the Peterson Foundation is partnering with Milbank to work with 5 different states on looking at doing a better job doing cost containment and quality improvement, and 5 states were selected there. I think New Jersey was one of them. And so when something like that happens, identify how you might be able to fit into that before the details are worked out and maybe part of that plan. So once you kind of get the idea generated and folks are behind it, the next thing is what's happening in your state to try to figure out the best way to get those services reimbursed by Medicaid. I think as Ryan, I think as you pointed out, it's not always Medicaid that it will pay for it. Medicaid can't afford to pay for all this. So making sure that you're partnering with other folks, other social agencies across the state. So I don't know whether that has triggered anything for the panelists that we have now, or any other thoughts about kind of taking that from idea, once the idea has gained ground, how we actually get that to be implemented into the Medicaid program.
And sorry, I stepped out. I had something I just got pulled off into. And the question was, what comes next as far as implementation steps?
How the idea gets implemented. So in your example with the doulas, you guys identified doula was important. And this is one example, you certainly might have others. But then you needed to figure out how to get it paid. And as you pointed out, you worked with the managed care plans to make sure that they had a way, because you're a 95% managed care state, you worked with and figured out ways to make sure that the managed care plan paid for it. What are there other ways of, once that idea has gotten a stronghold, folks have agreed it's the right path forward, what are the next steps that need to get into play? Sometimes if it is extra dollars, there needs to be a legislative change. And so you've got to work with the legislature. And if it's only every 2 years, as in Texas, you've got to figure it out timing wise that has to happen during that critical window of opportunity.
Well, I would push back a little bit on the linearity of that. I think if by the end of the time you institute a policy, you haven't brought your MCOs on board, you're going to have problems. So we had them as one of the essential stakeholders at the beginning when they started this discussion, and this went on for months to years. And so when we did reach the point where we were ready to go live, we had already worked out a lot of the potential hiccups that were going to occur, and the MCOs knew those and could anticipate those in advance. In addition, what we did in New Jersey Medicaid is we established 2 individuals that are our doula points of contact, that if there are any issues that come up from providers, from members, or from any stakeholders, that those would be the individuals that would help them to address any gaps that are coming to fruition as this goes live, because inevitably when you're going to start a new service and you're going to introduce a new provider type, you're going to have issues. And so those are the ways that we tried to smooth over the implementation, and so far it's working pretty well.
I just want to reiterate that we have these as 2 different steps here, but I think you're exactly right that from the get-go, the closer you can work with the payers, whoever that's going to be, the better it will be. So it's not just now we've got to introduce this new concept. So I think I would venture to say that one of the reasons you were successful was because you did invite them to the table from the beginning. And I think that's a really wise piece of advice.
I just wanted to add on, Marie, that I wrote down in the corner of my paper, it's the relationships matter. You know, I think one of the things that I hope this couple hours that we're spending together does is it demystifies some of this. I mean, Ellen Marie and I, and a lot of us talk a lot about the authorities, who we have to get them from, how to work with the legislature. But in the end of the day, all this really comes down to is saying, do you have a program that will improve the health of the kids, and do you have the relationships to sell it to those people? And then what we're hoping to do today is to help this whole crew understand what those relationships are, and what the limitations and possibilities are in the Medicaid side of this whole thing. So I think that's I think it's super important. I also, maybe this is a little bit of a diversion, but I think that at the state, and I think my colleagues could speak to this, there's not always a moment, but there's sometimes a moment when you know you're successful. And for me, sometimes it was when the head of the Health Finance Committee in the House started repeating back to me what I said. Or when the MCO CEO decided to take this on as something of their own. So it's sort of like, so I think to Tom's point that if you go to the MCOs at the end, it's too late. I think that's absolutely true. You have to build that relationship over time. Not doing
Hey, Jeff.
Yes.
Just one other thing that comes to my mind when we're talking about, implementation and post-implementation, and I mentioned this earlier, is how do we level this up? Level it up again in smaller, rural, underserved areas that maybe, in the example of Texas here, this specific example, aren't connected to a major academic children's hospital and have those resources. So there's that. And how do we level this up with other MCOs? Again, in our Star Kids program, we have 9 Medicaid managed care organizations that operate throughout the state. Some of them are smaller non-for-profit community plans, but we also have some much larger national or enterprise level plans as well. And some, want to play in the sandbox and others don't. And so how can we tell this story? Is it proving that it's cost neutral or there is a return on investment? Is it telling the story or showing that graphic that Dr. Burhani worked with their families to create? And because, I think some of this is becoming, or if not already, a best practice. And so how do we convince the other plans who at the end of the day are competitors with one another? How do we convince them that this is the right thing to do and it's a best practice? And I haven't completely cracked that nut yet, but it's about relationships because, I'm going to have a relationship with one of their medical directors and I can say, hey, come see what's going on. There's one plan that's really engaged. What can we do to get you involved in this too? Because again, providers are working with multiple MCOs. And when you have something like this that is going to be or is a best practice, it would sure make sense that you're going to do this for not just your patients that have health plan X, but for all of the health plans that you're working with. And that also goes for commercial books of business too, to be quite honest.
Yeah.
Jeff, can I ask Ryan a question? And maybe it'll even reflect to the other panel if Tom is still on, and or Ellen Marie. So on the one hand, I'm really excited because we've identified a potential level of finding MCOs, but the reality is there often are multiple MCOs and trying to figure out who wants to come to the table, who's willing to come to the table. And I've been in meetings with MCOs where they've actually said explicitly, we don't want to be known as the special healthcare needs MCO. So come back to us eventually. But here's my question. What can happen within the Care Coordination Academy structure? And potentially what could be the role of families and Title V to get the MCOs to come together on a core set of potential outcomes? I'm choosing the terminology core set there to distinguish it from the Medicaid child and adult core sets, but there could be overlap. But the very heterogeneity of the MCOs is starting to give me agita because I could see delivery systems needing to decide who gets high quality care coordination because it's in their benefit scope and who doesn't. And so can you guys riff on that a little bit?
I'll start from the federal level and then look to the colleagues. One of the things is not having to do it with each individual managed care plan. I think that, and I think we lost Dr. Kelly, but it sounds like in Pennsylvania and in other states, that can be written into their contracts the same way. Because I think as a clinician, that's the last thing we want is to have everyone do their own thing. So if in the managed care contracts, it's decided that every state Medicaid MCO needs to report on the same measures, the states can do that. The states can move that forward. And I think some of the examples, you then can provide the incentive to the managed care plan, the equity incentive, for example, that Dr. Kelly was talking about. There was a couple things. The home visiting, they then required that 2 visits to a home visiting needed to be occurred in new moms and moms with complex conditions. So there are ways that the state in either a state directed payment or in some other way, when you're negotiating with those managed care contracts, that you could put the same thing in all the contracts so that then it becomes a unified process. And that's a little bit, I think, about what we do with the doulas in New Jersey, right? It sounds like that was in all the Medicaid contracts that the doulas had to be paid.
Yeah, and to that end, and granted, we only have 5 MCOs in New Jersey. We don't have 17 like in Texas, but we have only one managed care contract. There is only one contract that goes out to all of our MCOs. There really is no negotiation between MCOs, and that meets that end right up front.
This is Dave Kelly. I'm back. So yes, we do put a lot of these requirements in our contract so that, again, there is no haggling, there is no cherry picking. All of the MCOs have the same requirements and we hold them accountable. We have teams that monitor them, and if they're not doing what's in the contract, I'll just say there are consequences. They don't like to be cited for being out of compliance because that's an NCQA no-no in their accreditation. So we can hold them accountable. with specifics that are in the contract.
And without breaking any FTC regulations, the core elements of those contracts, and not the contracts themselves, but the components around care coordination, can that be shared amongst the Care Coordination Academy membership as a series of promising, if not best practices when it comes to care coordination?
I think from our standpoint, I'll have to go back in and look. Our contracts, I don't know, a couple hundred pages long, but it's publicly available. You just have to know where to search, where there are various care management components. There's a section called community-based care management. There's sections around all of our incentive programs. It's all publicly available though. And I can send, I'll see if I can find some links that I can send to folks, and you can look at. The problem is being able to search within that link and finding where the contract language is. I know that there's language in there. I sometimes have trouble finding it in a huge PDF document, but it's all publicly available. And I'll see if I can find a basic link and put that in the chat.
That would be
the same goes for, and the same goes for New Jersey, although ours is pushing 800 or 900 pages. So make sure you don't hit print when you are looking at it.
Yeah, and just to be clear, it's specifically the elements of what care coordination for CYSHCN and or CMC is. If there are states in this area and MCOs are involved in that work, that actually is a nice, foot under the tent, so to speak, so that the Academy members can begin to move this forward. And then, Ellen Marie, to the extent that CMS and CMMI are continuing to track this, because as we all know, when we look at those core sets, there's very little that's specific to CMC on the core sets. ADHD is about as close as we get, maybe depression and follow-up, but we've got to start building that trajectory into meaningful measures for these complex and vulnerable populations.
And Jeff, I'll just say that sharing contract language is something that we've heard that states are interested in sharing, that since it's publicly available, there's no fear of landing in an orange jumpsuit by sharing some of this. But when it has been successful and where we think that there have been ways that worked well with a managed care plan, I think there's lots of good reasons to share that. And Jeff and I were just talking over the past couple of days about they're the kinds of things I think that this CoIIN could do a good job sharing, how you made it through to your Medicaid agency and what you demonstrated, like Ryan talked about, what was successful, what worked there, how do you tell your story? And then once that happens, was there certain kinds of contract language that you felt was successful and got in there, and be able to share some of that across different participants in the CoIIN?
I want to add one quick, I don't know if it's a counterpoint, but just kind of one other dimension to this. And I certainly don't want to paint the picture that everything is perfect in Texas, because we are far from perfect. We have so much more work to do. We have had contract language for quite some time, again, that stipulates for this level of complexity, you must have X number of touch points each year. This many need to be in person. And I will tell you, again, reflecting on when I was full-time provider clinical, there's still something missing. I mean, we can have a contract provision about the MCO must post the child's assessment on their portal. But at the end of the day, that doesn't mean that I was ever able to see that, because there's 5 MCOs. They all have a different portal. It was faxed to me in my fax machine, eight half of the pages. And there's still, other things that are just, and again, maybe to Jeff's point, it comes down to relationships that we still know that those service coordinators are just not collaborating with the medical home. And that's really a shared thing. It's not just the MCO's fault. It's not just the provider's fault, but if the service coordinator is trying to call me in my clinic, I need to make sure that she or he has a way to actually talk to me or my social worker and doesn't have to wait on hold for 45 minutes for our call center. And so I think the contract language is important. It's a foundation, and it probably can be strengthened for sure. But it's again, how do you get at what's really happening at the level of care, and is it really working? I think some of the MCOs have tried to solve this by actually physically embedding service coordinators in actual practices that have a high number of children with special healthcare needs. that's really helpful for some practices, but it just doesn't work again in a smaller practice that literally doesn't have a desk for that person to sit at. And so I think we're all still trying to figure out, again, what are the best practices where the rubber meets the road. And I would love to hear from others if someone else has found a way to get at some of this softer stuff that isn't, a contract provision, how many, visits you need in a year.
So Ryan, I think you bring up this really important point that the contract is good, but it's, like any contract, it's how it gets executed. I think, so I think contract language, I have to tell you, I've been thinking as we've been having this conversation, I wonder what the health plans would do if we said we're going to give out a couple awards to ones that the families would judge, about how well they worked, but that's a whole nother, that's just my maybe a dream. I want to go, I think we should, Ellen Marie, I think we should go in do one little quick visit to ACE Kids, because there's a little bit of talk about that. If you would spend a little bit of time on that. And then I really want to I think we ought to spend the time we have left, and this time went fast. I thank everybody for hanging on, and talk a little bit about measuring progress and success. Because I think that's, Rich hit on the core set we've talked about, but there's also a great comment in here from Christine about how families view capturing quality of life. So Ellen Marie, would you mind talking for a minute about ACE Kids and what that is and where it's going and what it may or may not give us?
Yeah, and I'll apologize in advance. I know there's been some things that have happened more recently, and I'm not completely up to speed on that. So again, I have a little list of things that we can come back and dig into a little bit further. But the ACE Kids Act basically ended up being, I talked a little bit about this health home that we have, and that's been around since the Affordable Care Act, where the state can get a 90-10 match. So the state only has to prove 10%, the federal government does 90% to be able to offer what we're calling kind of enhanced health home, coordinating specifically with social service agencies. There's language in there that says it's not just coordination within just the medical community. In the health homes that was in the Affordable Care Act, it specifically says you cannot identify just a specific age population. So we've not been able to do that just for children. There has to be certain chronic illnesses there. The ACE Kids Act has created kind of a parallel track. I think and again, I can look it up as we're talking and get back with more of the details. I don't think it's for 2 years. Folks on the call probably know more than I do, but it's a similar kind of an enhanced match to be able to provide this service, but it's for a limited amount of time. So after the period of time, it would go back to what the traditional match would be. Enhanced match for 6 months. Thank you. The health home is an enhanced match for 2 years. So they get a little bit more to provide this extra care coordination. It can be specifically for children, which is the new thing. And then, so it might be kind of an on-ramp, if you will, for how states might want to pay for this. And we can certainly provide more information. We put a request for information out at the end of last year. I don't know that we've compiled all the information to ask the community how we should implement this. When I was doing my PhD in health policy, someone said that health policy is 10% legislation and 90% implementation. So how that language was written and how we actually implement it is critical. So because of that, we put out a request for information to get folks commenting on how we should be looking it through. Another big part of this was better understanding how, and this is, I'm sure, something for all of you, is how Medicaid can pay for care across states, right, for these kids that are living on one side of the river and where they're getting the health care is on the other side of the river. So I think we'd be happy to provide a little bit more information. I can get some of the other experts that we have that are working on the implementation of this to talk about that. So it's exciting. It's just new. And we're looking forward to seeing how many states, again, it's optional how many states pick up on it.
Great. I think maybe
there's been a lot of questions about measurement, so I want to make sure we.
Yeah, I know. I think that's exactly where I wanted to go and talk about that. And I think maybe the question that I'm struck by most in the measurement conversation has really been around this and this sort of the measures that are part of core set or some of the sort of standard measures versus what the families are defining as important. So I wonder if it's okay, why don't we go back to our panel and maybe talk about that? I think, Tom, you could talk about the relationship of how you're looking at the doulas. Dave, I don't know if you want to talk about it in terms of some of the things that you've done in Pennsylvania and measures that aren't necessarily on the core set, which is what the states feel like they get judged on, or sometimes the plans, but through HEDIS, but measures that provide additional value and are closer to what the families and providers are looking at.
So I'll just keep going with our theme since we're becoming the dual state here. The measure that the sole measure that we've really implemented so far is the postpartum follow-up, the initial visit with the OB. We have pending legislation that's, I don't think it's been passed yet, where they were mandating another postpartum visit, I think a home visit, but that's not written in stone yet. And we're in a transition period when it comes to incentivizing our plans as to the measures that we use there. So I think that topic is very much in discussion for us. Our First Lady is very focused on health initiatives related to maternity and child outcomes. And so we're going to have outcomes that are going to be directly in that sphere. But right now, that's all I have to report on that.
But just to reiterate something I think you said earlier, Tom, I just want to make sure is this postpartum visit follow-up is something that you didn't dream up in the Medicaid office by yourself, that there was some feedback from the doulas, right?
No, actually, that was ours. And okay. It's a HEDIS measure, as I recall.
Yep, it is a HEDIS measure.
Right.
Yeah. Man.
So Jeff, just a couple things from Pennsylvania standpoint, a few things that we measure and have looked at. I mentioned previously, it's a relatively new program that COVID put a little bit of squash on, was doing the 2 visits, and they're not postpartum medical visits. These are home visitation visits to look at mom and baby. At a minimum 2 times for all first-time moms, as well as those that are determined to be high risk. And so one of the things that we're actually working on with our EQRO is we actually it's not done yet, but we're developing an incentive probably for next year is, and this is an MCO incentive, to look at how many moms actually had the 2 visits, and then we're coupling that with the well child visits. So that's an incentive program that will be new, I think, for our MCOs. Actually, I think it's for care rendered in 2021. So so that's something that we're working on to kind of back up that new program that I talked about with at least 2 visits. So it's a measurement and it's an incentive. So we're going to be running some data on that. For many years, we have developed a metric for access to care, dental care, for those individuals with special needs. And we have measured that for many, many years and have helped to see some improvement there and close some gaps. So that's another thing that over the years we have measured. We also, I mentioned previously that we measured those young adults with special needs that are transitioning out of traditional Medicaid that have wraparound services under EPSDT that we actually measure. And again, there's about 300 of them every year. We actually measure and we hold our plans accountable for making sure that they get transitioned into one of our other Pennsylvania waiver programs that we have, so that they don't miss they continue to get their wraparound services. So those are just, some of the things that we do that are I'll say outside of the normal quote unquote HEDIS. I mean, we do the postpartum visits and prenatal care visits. And we're going to be doing, again, equity incentives with our MCOs around the prenatal and postpartum visits. But those are some things that we're doing kind of outside of the normal HEDIS and Medicaid core sets that we think are important to our program.
David, if I can ask you a similar question to what I asked Tom, how did those measures come to be? You know, where did the incentive to decide that those are things you wanted to look at come from? And I'm sure it's probably diverse, but an example.
So I think that the programs happened because we felt that there were still needs out there in the community. And, you know, we're hearing from both providers as well as we have a very active consumer committee, subcommittee of our Medicaid committee, advisory committee. So, you know, we make program changes based on a lot of consumer feedback that we get. Our providers can certainly be vocal and let us know, you know, when things need to change. The access to dental care for special needs, that was developed many, many years ago. And again, there were stakeholder meetings, and it was one of the things that we put together. We developed that measure ourselves. We also, this new metric, we're kind of combining the well-child visit in the first 15 months measure with our own homegrown visit. But a lot of these programs come about because our providers and as well as our families have asked for them and have said, you know, there's some needs here that are not being met. And, you know, maybe Title V was doing some of these things, but is there a way to, codify this within Medicaid and make it happen within Medicaid?
Cool. We are
Jeff,
near
if I
the
could
end, but I
wrap
wanted to
up.
make sure Texas and Hawaii had a last chance to talk. If you guys had anything you wanted to say on the measurement side. Ryan
Jeff,
or
this is
Curtis?
Curtis in Hawaii. So I think the challenge for all of us is what are meaningful measures that are measurable? Yeah. So historically we did it backwards. We look at what's measurable, what's well defined, and then we pick the most meaningful measure. But I think the better way is to look at what's meaningful. But as long as we have something that's measurable, so that's kind of the challenge that we've been facing. We did add SBIRT in Hawaii as one of the P4P measures, and that was really helpful, although it wasn't really well defined when we added it over.
Yeah. SBIRT is a screening measure for substance use. So.
Yeah, and Jeff, if I could jump back in the conversation again. I only answered for doulas. We actually had a set of measures that we addressed. And the way we came about those is we just sat around and determined what we thought the priorities were going to be that we were going to address. And those, one of those, to Curtis's point, was, which I pushed strongly for, and I take responsibility, even though it ultimately proved not to be successful, was the preterm birth rate. I really wanted to know what our actual preterm birth rate was in the state. It became so prohibitively difficult to actually determine that we had to abandon that as a, but the other things were tied to HEDIS and national cores, like A1Cs over 8 and BMI measurement and compliance with prenatal care, things like that. So it is a mixture of practicality and of measurability.
Great. Man. Ellen Marie, we are at time, so I wanted to give you a quick closing moment if you would like it, and I'll just go first for 1 second, say this has been an incredibly helpful conversation, I think, and I always worry that we'll have enough to say. Well, that is never a problem. So, Ellen Marie, do you want to close us out?
Yeah, I'll just echo that. I think, first of all, thank you for inviting me to participate. We have been working with a lot of you on different fronts, and it's nice to pull it all together. We think that Medicaid could be an important part of sustainability for you. It may not be the only way. I think as Ryan noted, there's other folks across different states that coming together. I think that there's some renewed interest in having the federal government figure out how to maybe help you do this. We put out this how-to or the toolkit on value-based care. We did it on social determinants. So we've got that now, letting states know what they can do. I think now our next step will be how we can help states move along that continuum and do more of that. And so I think when Jeff and I were talking about what we wanted to accomplish, a lot of it was listening as well today. What other kinds of information do you need? We want all of your programs to continue at the conclusion of this award, and we want to figure out if there's ways that we can help make that happen. And so I think I've been taking notes of some things that we might be able to provide. And again, if this was easy, it would have been done before. Really appreciate it. Thank you from the federal government, and just thank you for all the families and the kids that you've been able to take care of. You guys are special heroes in the world of healthcare delivery, caring for these kids that have such needs, and the families and the caregivers. So really appreciate all the work you're doing. And again, thank you for inviting me to help participate in this work.
Great. Heather, are we back to you?
Yes, thank you so much. Thank you, everybody. That was truly amazing. I think we all learned so much. I really appreciate everyone taking the time to be here today. And Ellen, thank you so much for your perfect moderation. That was excellent. So we now have about 20 or so minutes to take a break. So please take care of yourselves and then return back at 2:50, and we will then go into team breakout groups.